Hi, I'm Sandi Lam. Thank you for this opportunity to speak at this virtual conference. Today, I'd like to talk about health services research in pediatric epilepsy surgery. We know that surgery is helpful in well-selected patients and can make a huge meaningful difference in seizure burden and quality of life. We have a lot of data sources at our disposal to help study this problem, from local institutional data to national data sets. This is a big problem because resource utilization for children with chronic complex neurologic conditions accounts disproportionately for a high amount of total hospital days and total healthcare utilization in this country. We know that there are a number of National Association of Epilepsy centers that are accredited to take care of patients in a multidisciplinary manner. For each center, there are over 4,000 patients with refractory epilepsy. We know that number of patients with active epilepsy is high. Now, how can we reach more of these patients? And how can we determine how we can help patients with epilepsy surgery? Now, we all know the rationale for epilepsy surgery, and especially in children. It is to help stop the detrimental effects of recurrent seizures and also the detrimental effects of the side effects of anti-seizure medications. The goals are seizure freedom, or reducing the seizure burden, and to improve the quality of life, and to also reverse the effects of encephalopathy, where developmental stagnation and regression can occur. In children, taking advantage of the plasticity of the developing nervous system is important. Now, there's a huge role for surgery. There are many surgeries, as well as evolving roles of developing technologies. We know in a randomized controlled trial in neurosurgery done in 2001 that epilepsy surgery helps. Now, how come we know this, proven from a randomized controlled trial and multiple health services research studies showing that healthcare costs and utilization after epilepsy surgery are lower for direct medical care costs and healthcare utilization for patients who had had surgery compared to medications, and yet we still need to do these studies. We're not able to reach the patients that can benefit from surgery. Here's another study from the FIS database looking at children with refractory epilepsy on medications only or medications plus surgery. In over 2,000 matched pairs, we can see that at years 1, 2, 3, 4, and 5 after the index date of epilepsy surgery or continuing with medications, that the outpatient, inpatient, and emergency department settings, the healthcare utilization is lower year over year after surgery. Now we can see at the 2 and 5 year time points, there's a reduction in inpatient visits, emergency room visits, and also in anti-epilepsy medication use. Now, who's getting surgery and who can benefit? There's increasing utilization of pediatric epilepsy surgery in the US, but it is still underutilized. The overall number of epilepsy surgery cases per year are lower than 35% of kids who are expected to be surgical candidates, based on epidemiology studies done in Connecticut out of Yale. And we know that disparities exist based on race and insurance. And this is shown in US studies and shown in other countries. Now, in neurosurgery, we continually try to improve and find better ways to do surgery, to innovate and to do surgeries better and safer and more effectively. But in order to have good surgical outcomes, we actually need to find the patients who can benefit, make sure they have appropriate timely referral, have the proper workup, and that we have the right patient selection. What happens to patients even before they get to surgical evaluation, and how do we identify and lower those barriers? When we looked at our own institution, we actually found that patients of non-white race had a longer duration of epilepsy before receiving epilepsy surgery, many by over 3 years. These patients actually traveled a shorter distance to the hospital. Now, how do we interpret and learn from these findings? Do patients get appropriate and timely referral? Are there barriers in access to care? Are there socioeconomic barriers? Are there ethnocultural beliefs that we don't understand? Are there issues with health literacy? Do we need to educate primary care doctors more? How do we manage expectations of all stakeholders? In a study out of Philadelphia, looking at barriers to surgical evaluation for patients with epilepsy, actually looked at the workflow within the institution. By process maps, patients who had intractable epilepsy and receiving the workup were identified and mapped out to see when the time to conference was in discussion for multidisciplinary epilepsy surgery conference. And by designing implementation for interventions to decrease this amount of time, this was shown to be a durable intervention. Now, quality improvement is often very local, but we also need to look on a national scale. We can also define at-risk times to see when to offer appropriate intervention and support. So here we looked at insurance transitions and healthcare utilization for children with refractory epilepsy across the country. We defined a cohort of over 3,000 patients. We actually looked at the number of insurance changes over 2 years for kids with intractable epilepsy. We see that people who had changes in insurance twice within this time period were actually at higher risk for ER utilization and overall higher healthcare utilization. We see that the role of stable insurance, including Medicaid, actually has an important role in health of these at-risk patients. Now, we also know that every time that we see patients in a neurosurgical setting is also an opportunity to be able to address these other socioeconomic issues and social determinants of health. So when we look at how to study epilepsy surgery, we actually have to study epilepsy and also socioeconomic factors, health services research, and we have to understand how to communicate this effectively to be able to reach all of the patients that we need to who could be good surgical candidates. When we look at diagnosis codes for epilepsy and making sense of the real world data to be able to use this in research and optimize it in real time for healthcare delivery, we can look to the future for how we can make sense of these codes. How do we develop computable phenotypes for pediatric epilepsy? An example is Lennox-Gastaut syndrome. We can see if we just pull by face value of the Lennox-Gastaut code, we would be missing a large number of patients. Now, when we look at data verification and validation studies, we can start to develop computable phenotypes for every type of epilepsy we want to study. Now, a lot of this is in progress. We're joining forces between health services research, AI, machine learning, also quantitative and qualitative approaches. So this was a whirlwind tour of the approach to studying pediatric epilepsy surgery. So thank you very much for allowing me to share.